находимся не
Okay. Please press plus in our Viber chat if you hear me well and if you joined, please. Do you hear me well? No problems with it? Okay, so Rams told me that everything is clear with sound, that sound is much better now, so we will try to start again normally with better sound. Okay, so degenerative-dystrophic diseases of joints is a very big group of diseases that have a different clinical picture, but has similar pathology, pathogenesis, etc., etc. So first of all, we must know that what is osteoarthritis, also known as like arthritis in literature. This disease, this group of disease, firstly damage every articular elements, articular cartilage, and secondary some hodral part of the bone. Synovial membrane, ligaments, capsule, pararticular muscles, etc. So first of all, you see that this is a cartilage. This is effect of it, and the epiphyseal part, subchondral bone, much closer to joint is synovial membrane, and these parts affected after affection on cartilage. So what about epidemiology? So first of all, the main problem that affects joints is weight bearing. So if patient suffers from big weight, so from obesity, this patient definitely will have osteoarthritis when he will be more than 65 years, for example. And secondary is age. Typical for osteoarthritis is age, that more than 65 years. But it's very common to primary osteoarthritis. Also, it's more common in women that are in postmenopausal period. Also, it has familial tendency. You know well that obesity are also familial, and actually those patients that have obesity, that have familial obesity, will also lead to this weight bearing of joints and to this problem. Okay. What about pathogenesis? You should know that actual main parts of of every cartilage is chondroitin sulfate, keratin sulfate, and hyaluronic acid. And due to this disease, these parts are degraded. The quantity and quality are much less, and these parts, these glucosaminoglycans, protects our joint from any factors, for example, weight bearing. And due to this disease, these parts are much less in quantity and quality, and it will lead to its degradation and to osteoarthritis. Okay, and when we say about etiology, it's a primary and secondary osteoarthritis. When we have no obvious predisposing factor, it's primary osteoarthritis. When we have systemic disease, trauma, etc., we can know that this is secondary. Causes of secondary osteoarthritis are, first of all, it's developmental. It's hip dysplasia or hip luxation. So if this child could not be treated during childhood, it will lead to hip dysplasia. It will lead to secondary osteoarthritis when this, mostly women, will affect due to 30 years old. And endocrine is acromegaly, very common traumatic part. When you know that patient got intra-articular fracture, you definitely will know that this patient will suffer from secondary post-traumatic osteoarthritis. Inflammatory is rheumatoid arthritis and gout. It's the most common, very close to osteoarthritis disease that we must differentiate from it, and this also can lead to secondary osteoarthritis. Metabolic Wilson's disease, aseptic necrosis. Aseptic necrosis is the second part of our topic. We will speak about it later. And neuropathy, syringomelia, and diabetes. You know well that diabetes can affect neurons. Also, it could lead to osteoarthritis, but not very common. What about clinical features? First of all, for every disease that called arthritis, common is stiffness. Morning stiffness is very common, but for patient with osteoarthritis is common stiffness that leads less than 30 minutes, up to 1 hour. What about pain? This pain increased when patient moves and decreases when patient rests. And sometimes we can mention restricted functionality. Sometimes if patient have big degeneration of chondral part, some parts of of cartilage can break down to joint, and it will lead to blocks by osteophytes. And blocks of joint could also be by rupture of meniscus. It's acute rupture, but sometimes, similar to and typical to this to osteoarthritis is degenerative meniscal repair. So it will also lead to it could also lead to rupture and to blocking. Differential diagnosis of osteoarthritis, rheumatoid arthritis, and gout. First of all, osteoarthritis have no systemic symptoms. They are not present. For rheumatoid arthritis, know well that patient will have general feelings, and gout also. Duration of morning stiffness. For osteoarthritis, as I told previously, morning stiffness are less than 1 hour. For rheumatoid arthritis are common more than 1 hour stiffness. And for gout it depends on stage and affection. Nodules. Due to osteoarthritis are common typical nodes of fingers of distal and medial joints that are called Heberden and Bouchard's nodes. And for rheumatoid arthritis, these nodules are absent. It's not common. For gout, there are tophosis, no Heberden Bouchard's nodes, and there are tophosis. Okay. And pain with movement. Due to osteoarthritis, movement increases pain. Due to rheumatoid arthritis, movement decreases. Pain relieves. Due to lab findings, first of all, rheumatoid arthritis anti-reactive protein antibody are negative. So, due to osteoarthritis, you will have no any typical blood test features, and due to rheumatoid arthritis, for sure. And due to gout, you will see it for sure. Okay. And what about age? Typical, as I pressed, typical for osteoarthritis is more than 50 years. For rheumatoid arthritis, more than 20 years, and gout, 35 years. I just want to remember that for secondary osteoarthritis, post-traumatic, it could be 20 years, etc. But common is 50 years old. What about investigation? For osteoarthritis, the main investigation factor, most common, most widespread and very informational method is X-ray. On X-ray, due to different stages of this disease, you will see different features. But for severe osteoarthritis are common joint space narrowing. As you see, this part of joint are close to normal. It's a lateral part of joint, and the middle part, medial part, is narrowed. On X-ray you can see cartilage. This cartilage is X-ray negative part of joint, so actually this part is a cartilage. It's a part of cartilage of the lateral part. It's quite normal, and for sure medial part is degenerated. There are no cartilage here. Also subchondral sclerosis. Closer part to most narrowed part of joint will be white. It's sclerosis, yes, white part. And vaginal osteophytes. You see this osteophytes here and here. It's very common for osteoarthritis. Here you see 4 stages of Kellgren and Lawrence classification. So here you see normal cartilage part, normal distance between femur and tibia. The second stage is narrowing. You see this cartilage and this are different. This X-ray are more narrow. The third, when you see osteophytes and narrowing, it's third stage on Kellgren and Lawrence. And fourth stage is no cartilage on one part, from medial or lateral or both. If you can't see any cartilage, is a fourth stage of Kellgren-Lawrence. Arthroscopy is another, it's a golden standard of diagnostics of osteoarthritis, and this classification is Ote-Bridge classification. So you see on the first stage you just see this that cartilage just loosening. It's quite normal. On the second stage you can see osteomalacia, chondromalations. You can see subchondral bone, but just some degradation of cartilage. It will look like this part, just small degradation. And the third is, you see, you can also see big part, big area of chondral dystrophy. And on fourth, if you see due to arthroscopy subchondral bone, is a fourth stage on outer bridge. And this you should know that arthroscopy and X-ray could differ from each other. For example, patient can on arthroscopy has third stage outer bridge. This patient definitely will have pain and stiffness, etc. But on X-ray he could look like on the second or first stage on gangrene Lawrence. So golden standard of diagnostics is arthroscopy, but this is invasive method. More widespread is X-ray. Computed tomography and MRI are also widespread, but less informative than X-ray. So doctors can use it just to investigate another parts, ligaments that can also be part of osteoarthritis, but not for cartilage part. Okay. Investigation, as I told, blood test, everything will be clear on everything, rheumatoid factor, etc. So when we say about treatment of osteoarthritis, you must know for sure, and we must remember that osteoarthritis, this disease, can last for many years. So patient can be treated operatively firstly. He first of all must know how to treat by himself without any pharmacotherapy and without surgery. So patient, first of all, if patient has obesity, he must work with his weight. He must provide weight loss. Second is exercises. Exercises that increases muscles will lead to decreasing of pain. Muscles are good stabilizers of joints, and these joints, the muscles will lead to decreasing of pain. So exercises, weight loss, yes. What about footwear? It's also not common to use such shoes. First of all. What about pharmacotherapy? You know that paracetamol is the first stage, the most common medication of osteoarthritis, and if you treat patient with osteoarthritis, you must use the most weak analgesics to most severe, most strong. Paracetamol is weak, NSAID like ibuprofen is middle, and opioids are severe analgesics that will lead to a decreasing of pain. Also, there are intra-articular injections for patients with severe pain, for patients that are very aged, maybe 80 years, that could not be treated operatively. You can provide intra-articular injections of betamethasone, and it will lead to more fast degeneration of cartilage, but patient will never feel pain after it. And hyaluronic acid. I've mentioned that hyaluronic acid is a very serious part of synovial fluid, So if you inject hyaluronic acid, it will also lead to decreasing pain. What about surgery? First of all, it's arthroscopy. You can see on this picture debridement of it. Also, you can provide resection of meniscus rupture, if you know about this rupture. But in patients that are on third stage of osteoarthritis, you must know well that debridement will lead to nothing. For every patient, that there are a lot of information about it, many investigations, many articles about it, that actually just exercises and weight loosening will lead to better results than debridement. Also, with the common vaporization is a debridement with temperature. It's also simple, but not very effective on third stage of it. More interesting and more effective way of treatment is microfracturing. Microfracturing can be provided to patients with third and fourth stage of osteoarthritis, using arthroscopy, and you must know for sure that after this procedure, patient must not bear that operated leg for at least 1 month, and sometimes it can lead to very good results. As you see, it's like second part. You can see degradation, yes, of cartilage, but it's the second stage on orthobridge. You see, it was first microfracturing, and after 8 months, in that patient, it leads to a good result. Other interesting method of treatment of osteoarthritis is osteotomy. When you see varus or valgus or varus osteoarthritis or medial osteoarthritis, you can provide osteotomy that will decrease bear on medial part, and it will balance bearing on both parts. But actually, firstly, to osteotomy you must provide arthroscopy and look on cartilage. When lateral part is also very degenerated, so for example lateral part are also on third stage, this operation will be useless. And the most effective way of treatment, like golden standard of treatment of patients without any different contraindications for operations, is arthroplasty. There are a lot of different endoprosthetics, but actually it reduces pain for sure, and there are different ways of fixation. There are cementless, cemented endoprosthetics, and the most common arthroplasty is arthroplasty of hip and knee. Arthroplasty of knee is very narrow and of humeral joint, because there are a lot of contraindications to do this, and the most effective way of treatment surgically of osteoarthritis of ankle is arthrodesis. Arthrodesis can be provided by different ways, like this with extrafocal fixator. This operation leads to destruction of all cartilage, and for union of tibia and talus, and this operation leads to no function of ankle joint, but it will lead to decreasing of pain. The most effective way of treatment of ankle osteoarthritis is arthrodesis. Okay, so, and as I told, one of very widespread problems that can lead to osteoarthritis is avascular necrosis. avascular necrosis, also known as osteonecrosis. It's a problem that are a result of interruption of blood supply, and this problem can be in very early age. For example, yesterday I treated one patient that is 20 to 21 years old with avascular necrosis, second stage. And this patient is a drug abuser. It's one of the most widespread risk factors that can lead to this. Also, it could be alcoholism, joint desiccation, bone fracture. It will definitely the most common risk factors of avascular necrosis. Okay. So this is X-ray of typical avascular necrosis first stage. First of all, you can see like zone of osteonecrosis. Firstly, patient will feel just pain and some joint dysfunction. So this patient will have no, or sometimes have X-ray features, but firstly he will just suffer from severe pain in hip. When we say, for example, avascular necrosis, first of all, this affects femur and its head. And the second, this fracture of this osteonecrotic part. You see this big degeneration, big problem, big fracture of head of femur. And the third part is reparation. You know that actually this head try to remodulate, to apply, to configurate to acetabulum. And the fourth part will lead to secondary osteoarthritis, is also here and here. And actually this patient will be unable to move because pain is very severe. It's simple to osteoarthritis, but it can move from first stage to fourth in 1 year. It's very fast disease. It's big difference between osteoarthritis. The most widespread and effective way of treatment of this patient with avascular necrosis is just arthroplasty. Sometimes surgeons provide tonalization of femur and use their different regenerative factors like PRP and for example PRP and bone marrow aspirate, but there are no enough data in literature that these procedures are very effective. They could be effective maybe for 1-2 years. They just can make slower this disease, but in result, every patient with this problem will be treated operatively, total arthroplasty, like in this patient. Also, I prepared for you some X-rays just to speak, because X-ray, as I told previously, very widespread method of investigation and very interesting, very informative. Look at this X-ray. As you see, narrowing, yes, of joint, osteophytes. Yes, here you can see this like normal, but you also see degeneration of cartilage. They are not very clear anatomically, and you see also here, it's not very clear. This is X-ray of patient with, you see, this is the second stage of osteoarthritis, and this is third stage, and you see a small osteophyte. osteophyte here. This is X-ray of total knee arthroplasty. It's a hinge endoprosthetics of Smith Nephew, American, and the hinge could fix every problem with instability of knee, because some problems of arthroplasty of knee is instability of components, instability of knee, and this joint, this type of joint endoprosthetics lead to fixing of every problem of instability. This is another one, X-ray of this, like third stage, yes, osteophyte, narrowing. This is X-ray of avascular necrosis with secondary osteoarthritis. You see this patient can't move, there are no cartilage here, just big degeneration, severe pain, inability to move, shortening of leg up to 2 centimeters. This is X-ray of typical primary osteoarthritis. You see, head of femur are like normal, just little uncongruative part, and the osteophytes just narrowing, and osteophytes. This is X-ray of patient that had fracture of femur's neck that was treated using screws, and you know that this method is not very effective. It led to pseudoarthrosis of it and secondary arthrosis, post-traumatic. On this X-ray you can see also avascular necrosis, cysts that fractured, that broken up. In this X-ray also avascular necrosis, typical cysts. And actually you can see that you must know for sure that every patient with avascular necrosis must be treated using arthroplasty, the most effective way of treatment. Okay, so I think it's enough information. Any additional information and any additional questions you can press in our group in Viber. Thank you, and we'll continue our work later. Goodbye.